everyone. This is Dr. Shirlea North from North Star Physical Therapy, and welcome to the new year. We are recording this episode in 2025, so I am super excited to start the new year off with everyone. For those that have been following, thank you so much for your support. Thank you for spreading the word. Thank you for trying to help me normalize these kind of conversations with your family, with your friends, and know that there is help there. For anybody dealing with any pelvic health condition or lymphatic condition like lymphedema or lipedema. And for those that are new, welcome to the tribe, welcome to the community. I hope that these podcasts really shed some light on some really common topics and questions and conditions and things that I see often in my practice. They're getting asked about a lot. And so this is just a forum for me to spread the word, spread my medical knowledge out there, and just to help empower you and to give you some good education, not misinformation, right? Because there's a lot of that out there, but for you to be able to make the best medical decision for yourself and to advocate for yourself, because that's really the medical climate that we're in now. So with that being said, we're going to start the year off with talking about drum roll, urinary incontinence. So urinary incontinence, we just want to go over some really basic stuff right now. What it is, what are the types of urinary incontinence, just really basic one-on-one things, and be on the lookout for other podcasts when we get a little more into detail of things. But I just like to start the year off of what is normal, what is not, what is common, what is not, all of that good stuff. Let's hit the ground running. So first, we want to define urinary incontinence is when we are not continent or not being able to hold our void, hold our urine, either throughout changing of position, throughout different pressure insults like sneezing, laughing, coughing, jumping, or when we have that really big urge and we just can't make it to the toilet in time. So let's just put this out there that it is common to have these symptoms, but that does not mean it's normal. Okay, it is not a normal part of aging. It is not a classified normal part of a pregnancy, let's say. It is not the normal, quote unquote, side effect of a prostatectomy or a hysterectomy or any kind of ectomy within the abdominal cavity. Is that a common symptom? Yes, but it is not normal. Okay, so stress urinary incontinence means that when there are stressors put on the system, like intra-abdominal pressure, when you cough, when you sneeze, when you laugh, when you jump, when you run, things like that, like those kind of activities, if that brings on some leakage, that is deemed stress urinary incontinence. For urge urinary incontinence, that is when you have that sudden urge, whether it's a big urge or a small urge. When you have an urge and you can't make it to the bathroom in time and you leak along the way, that is classified as urge urinary incontinence. Mixed urinary incontinence is when you have both going on, and there's also a type called coital incontinence when you urinate when you climax during a penetrative act, whether that's vaginal or anal. And then there's also positional incontinence when there is, the change in position, for example, from sit to stand, from lying on your back to sitting up at the edge of bed. Some people tag that into a subtype of stress urinary incontinence, but there are different kinds of urinary incontinence. And that's why when a professional or a medical practitioner or a pelvic floor physical therapist asks you certain questions, we're not trying to be nosy. We're trying to really figure out what is going on. When are you having your symptoms so that we do the right treatment? So oftentimes I want to make sure I create a safe space where I can ask these questions to my clients so that we can get a better hypothesis of what's going on. So when I do a physical examination of the tissues of your joints, of positioning, of all that good stuff, that it is just confirming my hypothesis of what kind of incontinence and therefore leading us down the right path to treatment. Oftentimes, we see or hear this symptom again when someone is pregnant. The pressure of the fetus or the baby that's pushing down on the bladder doesn't allow that bladder to fill like it was when baby wasn't there. And so there's a pressure management thing going on there. And so we tend to maybe leak a little bit during the later stages of our pregnancy. Common, not normal. When we are status post a pelvic surgery, common symptom, not normal, right? When we are under a lot of stress, when there's a lot of external stressors, maybe we have an uptick in our urge sensation, common symptom for leakage, but not normal. I just outlined right there different kind of types of urinary incontinence, and you can see how with the different reasons why and the different causes behind the incontinence, that will help guide us to the correct treatment of the incontinence. Not every pelvic health condition is solved by a surgery or solved by like a magic pill or overnight. It took us this long to get this symptom because our body has an amazing way to compensate. So I often get people that come in here. I actually had it the other day that a client had over 30 years of symptoms and of different surgeries, different infections, different insults to the system, and expecting it to go away within one session. You're out of your mind, okay? It takes a while to really figure out what are the contributing factors to that symptom so we can treat at the level of each layer of that, like a little onion, right? We're treating a layer of contributing factors and see how your body responds to that change. And the hope is that it is reducing and resolving those symptoms and for you to rebuild your system in a better way to help manage so the symptoms don't come back. Or if there is an exacerbation, you know what to do because you're empowered. You have those tools in your toolbox. So, for example, if you have a urge and it is a really strong urge, but you know your bladder isn't full, but you're like, oh God, I don't want to leak and I'm going to do a lot of like just in case pees, we are setting our bladder up to recognize that, oh, when I feel it just a little bit, I'm going to get that signal sent to my brain because I'm so used to that routine of just in case pees. Or with the first urge I get, then I need to go to the bathroom when my bladder isn't full. That's going to set that system up that every time that bladder fills a little bit, we're going to have to go to the bathroom. Then we're creating an urge situation. And then if we're incontinent on top of that, can we see the problem here? There are some people that have urgency, but that are dry, that are not incontinent. That's a different episode to talk about that. But this is for urge incontinence, where we're having that urge, whether or not that's a strong urge or a little urge, but we are creating a pattern of behavior that is just setting our bladder up for like failure and setting up our pelvic floor that from the wrong signal being sent there. So, or if we are getting stress urinary incontinence every time we jump, every time we run. And so it's like we're now going to probably start reducing our activity because we're so afraid of leaking. And then we become weaker, or we're not participating with like family events or kid events and stuff like that because we're so afraid of leaking. So that can set the system up for failure. Mixed urinary incontinence, yeah, we have both going on. Coital incontinence is when we don't want to be intimate with our partner because we're so afraid we're going to pee ourselves and make a mess and all that other stuff. So that sets our system up for failure too. So all these things are very treatable. And so in terms of that, as a pelvic floor practitioner, I'm not only getting down to the why and the causes of the urinary incontinence, but also what are some lifestyle behaviors that we can very easily change and modify and make a huge result, make a huge change for something small. So for example, We're going to ask you questions about your hydration. How much are you drinking? What are you drinking? When are you drinking? So bladder journals are huge here, okay? We want to try and figure out the why behind it and what is our pattern of behavior when we are at work versus when we're at home versus when it's the weekend, things like that. So that way we can really tease out some patterns there. So if we're always getting a urinary incontinent issue, maybe overnight, like nocturia is what it's called, so overnight urination, and let's say we're gulping down a 20-ounce water bottle right before we go to bed, I wonder if we adjust that a little bit in the timing. That way the kidneys are able to fully filter that water about an hour or two before bed. So when we go to the bathroom, we're able to fully empty, and therefore we can sleep through the night and not have to wake up in the middle of the night. So different little things like that. Or how much caffeine are we doing? Are there any kind of bladder irritants that may be causing that? What is our environment like? Like sometimes I have a client who has urge incontinence episodes at work because they sit right next to the bathroom. So they're just getting this constant reminder. Or these just in case peers that like they pee before they leave for work. They pee when they get to work. They pee because they sit 30 feet away from the bathroom. They pee when they're about to leave. They pee when they get home. They pee before they go to the grocery store. They pee at the grocery store. They pee when they get home. It is ridiculous, right? So we want to see what is the frequency of urination, what is the actual severity of the urge during the urination, what is the activity that causes the leakage. So sometimes I do ask folks, hey, let's go ahead and do this activity and see when it occurs. Is it right away? Is it after 5 minutes? Is it maybe some of my higher level athletes or CrossFitters? They're fine for the normal day-to-day stuff, but as soon as they go to work out and they do a huge like barbell lift or a snatch or something like that, and snatch and catch, that's when they're leaking. How are you breathing? That's a stress urinary incontinent episode right there, right? There's a stressor on the system with pressure management. So now we're looking at how you're breathing. How are you positioned? If we are standing or sitting while you're urinating, if you're fully emptying when you're urinating, is there any external stressors that's making you like push pee or hurry up and pee? So that way you're not fully emptying and now we're double voiding. Or now like you went to the bathroom and then you like within the next 5-10 minutes, you leak when you're walking back to your desk. I was like, maybe you didn't fully empty. I just went over a very small tip of the iceberg of all the things that I look at as a pelvic floor PT of your lifestyle modifications. All of those things I just mentioned, they are very easy, fixable, adjustable things that we can just tweak a little bit and can make a huge difference on your system. And that was all external stuff. That one had nothing to do with any kind of internal exam. Now, we also want to make sure that we are capturing the whole person. So I'm looking at orthopedically. How is your posture? How is your positioning? Is there any back pain or back rigidity? How are our ribs moving so we're properly breathing, getting good pressure, being managed throughout the trunk canister, so to speak? And I'll be speaking more about that in the next podcast episode. How are those tissues in the pelvis? Are they tight or are they weak? A huge misconception with urinary incontinence is that our pelvic floor muscles are weak. And when we say this to some of family, friends, or even healthcare providers, I don't know how many OBGYNs and urologists I want to slap in the face because they are just not assessing the tissues and they're just telling people to Kegel. That is what is wrong with some of these practitioners that are not listening to the clients, not getting down to the why, not assessing those tissues to really understand. They may be so tight in the tissue that when there's any external insult, any external pressure, any external stressors, that they leak because of the tight tissue and not because it's weak, but because it is tight. Boggles my mind. So that's where there are these technologies out there like the Zella chair and other competitors that I think that technology itself has a place. However, the application of it is incorrect. There's no reason why a person should be sitting on a chair and get electrically stimulated in their perineum to have hundreds of thousands of Kegels being done in a sitting position. That's why it does not work for everybody, okay? So I am not necessarily poo-pooing the technology. I am poo-pooing the application of it, and that there are offices out there in medical community that are getting these chairs just to get a profit in their office, because it is easy for the client to just sit on a chair, get electrically stimulated, and say, oh yeah, instead of you actually actively doing the Kegel, it's going to do it for you, and it's going to solve your incontinence. Wrong. That is flat out bullshit wrong, okay? Kegels are for a very small subset of people that need to be able to isolate those tissues because they are truly weak. Now, if your provider internally assessed you to see that there is muscular weakness or there's a coordination issue, then yes, guided instruction and feedback on isolating Kegels may help your incontinence. However, about 8 out of 10 people I see here in the Northern Virginia, DC metro area, we are so type A wound up people that we are more tight than anything. We need to be able to build up resilience in the system, build in flexibility and down train, and figure out what's going on with the stressors on our system so that we can rebuild in a more functional activation of those muscles, like when we're working our glutes or when we're working our hamstrings or when we're working our core, not necessarily isolated Kegels. So Kegels are not for everybody that has urinary incontinence, okay? You need to make sure all these other conservative measures, all these other conservative things with your lifestyle, with your hydration, with your positioning, with your environment, with your stress management, with maybe medications could be having that side effect. Maybe what you're drinking and when you're drinking it is having that side effect. Maybe it is an improper weight that you're lifting at the gym, right? And then also being able to get a pelvic assessment externally and internally. We want to figure out all these contributing factors to urinary incontinence so we can properly treat it. And that is where a pelvic floor physical therapist is the best provider to work on this. The AUA, okay, the American Urinary Association, is Urology Association, in the United States, the number one treatment for a lot of urinary issues is pelvic floor physical therapy. We are the number one treatment, not a medication, not a surgery, us. So if you're having this symptom of urinary incontinence, whether it be stress, urge, mixed, coital, positional, if you're having that symptom, it may be common, but it is not normal. And I stress to you to talk to your provider or look up a pelvic floor physical therapist. In the United States, we have direct access, which means you don't need a referral. You don't need an order. You can just call us up, okay, and set an appointment, get assessed, get going with these lifestyle modifications, or get assessed on those tissues and see what's going on. We have a huge wealth of information and a toolbox of techniques that we can utilize for you to resolve those symptoms and keep them from coming back, and to give you the empowerment and give you the techniques that you can self-manage if an exacerbation occurs. For example, if someone has stress urinary incontinence and it's every time they cough or sneeze, that's the symptom, and they do it more in standing than in sitting, all things we can work on and fix as a pelvic floor physical therapist. And let's say it's cold and flu season right now, right? So you may get sick, right? We can't predict, oh, you're never going to get sick again. You may get sick. That happens. It's life. But now these tools and techniques, so your body has been able to build that up. So maybe we're not leaking at all or very little because you built up that system with resilience and you know how to manage it. And so I always empower my clients, like, I'm not expecting this exacerbation to happen, but if it does, work on these techniques for a couple of days or a week, or if it's like really bad, you give me a call, let's get back into the office and let's see what's going on, because probably there's another insult into the system that wasn't there before. I just want to stress that urinary incontinence is a very common symptom to a lot of different things, but that does not mean it's normal. We don't want to have a higher incidence of urinary tract infections because we think it's normal to be wetting ourselves when it's not. And another little side note, if you have burning, with urination, urgency of urination, and you go to get a urinary analysis, a UA, a urine test, and the test reveals a negative result, do not get on an antibiotic. There is no reason you need to be on an antibiotic when there's no infection present. I have had many clients that they have those symptoms and the provider just gives them an antibiotic and says, oh, we're going to culture it and just to see, and there's no active infection, and they keep the people on antibiotics. That screws up the gut biome, that really messes people up. I had a client that was on antibiotic after antibiotic for months, okay? And we have set up this system for a failure there, and now they have all these other issues within their pelvic floor just because of a negative test that the provider just gave them antibiotic for. Not everybody that presents with burning and urgency and frequency has a UTI. It doesn't mean it's urinary incontinence. That may mean there's other things going on, and that's again for another podcast, but I just want to put that out there, that be an advocate for yourself. If you have urgency and you have that frequency and you have that brain urination, it may not be a UTI. Definitely get tested for it to make sure so you can nip in the bud. But if it is a negative result, do not get put on an antibiotic. Go see a pelvic floor physical therapist. Go see maybe your urogynecologist or urologist, depending on the organs there. So that way you can get the best treatment, because it may be more like a nerve involvement or nerve irritation than anything else. But again, different podcasts for that one. I just want to plant the seed there when we're talking about urinary incontinence, because that's often a question I get too. So urinary incontinence is a very common symptom, but not a normal symptom. And a pelvic floor physical therapist is really your best provider to have on board so you can resolve those symptoms, build up resilience in your system to reduce any further exacerbations. All right, guys, I hope you learned some good tips and tricks and good advocacy from this podcast, and on to the next one. See you next time.